Thank you so much to the AARC for inviting us here, and also to Draeger for sponsoring us. I'm so excited to be here speaking today, and in particular on my absolute favorite topic, which is really thinking about how what we do in the mechanical ventilator impacts not only the lung, but the microenvironment of the lung, the alveoli and the alveolar ducts. And so this brings me to the title of my talk, which is Preventing Ventilator-Induced Lung Injury. Are we thinking too big? In other words, what we set on our mechanical ventilator doesn't necessarily correlate with how the alveoli and the alveolar ducts are responding. I have spoken at events that have been sponsored by both Draeger and ICON, and we do use Draeger equipment in our laboratory. However, they have no impact on the study design or the publications. So at the end of this talk, what I'd like to accomplish is to review the impact of different mechanical ventilation strategies on the microenvironment, recognize that there is a discrepancy between the microenvironment and the macroenvironment, and then reconsider what it means to have a ventilator-induced lung injury. So I thought this was interesting. I went to PubMed and I wanted to see where we are in terms of our research regarding acute respiratory distress syndrome, ventilator-induced lung injury, and the lung. And if we look back, and I'm going to probably favor this projector a little bit, and I apologize for that, but if you look back in 1975, starting out with the acute respiratory distress syndrome, we can see that there's been a remarkable increase in the number of publications up until about the year 2015. We're looking at the number of ventilator-induced lung injury and acute respiratory distress syndrome publications over here. And then if we compare this with the number of lung publications, we again see that there's been a similar increase in the number of publications. And of course, this is consistent with the fact that we recognize ARDS as a disease of high morbidity and high mortality, and certainly worth studying. But what we also recognize is that every year the number of publications themselves also increases. And we see that just by the number of publications that are related to the lung itself. More interestingly is the number of publications now related to VILI, or ventilator-induced lung injury. And we see that back in 1975, we were not that interested in ventilator-induced lung injury. Up until about 2000, this is when we start seeing a really remarkable spike in the number of publications. And so it's been really only in the last 2 decades that we've spent a lot of time researching ventilator-induced lung injury and trying to find resolutions for them. If we go back to the very first publication where we first identified ventilator-induced lung injury, this was a publication in 1979 in the Journal of Anesthesiology, and they identified pulmonary barotrauma. And they classify pulmonary barotrauma as the clinical manifestation of pneumothorax, pneumomediastinum, or subcutaneous emphysema. These are all very clinical manifestations of pulmonary barotrauma. And if we look at the patients that they were ventilating, they're looking at the peak inspiratory pressures that they're being ventilated on. And we see a nice normal distribution. The majority of the patients are being ventilated at PIPs in the high 30s. And if we look at the one patient that they claim manifested a clinically significant pneumothorax, it was this one that had a PIP of greater than 70. But the most interesting part of this study was what we defined pulmonary barotrauma as. We said that it had to be pneumothorax, pneumomediastinum. But what we recognize today, now 40 years later, is that pulmonary barotrauma happens in every patient, in almost every mechanical ventilator, in almost every breath, if we're not setting our mechanical ventilation appropriately. So we have subclinical barotrauma on a daily basis. We have subclinical ventilator-induced lung injury. And it's so important for us to recognize the settings that we're applying onto our patients so that we recognize this. So what do we know about ventilator-induced lung injury today? This was a publication by Hubmeier and Gajek, and they look at all the patients that were mechanically ventilated. In particular, they wanted to know which patients did not have injury at the onset of mechanical ventilation. In other words, which were the patients that required mechanical ventilation but didn't have an actual lung injury. And so they stratified the patients according to the presence of injury at the onset of mechanical ventilation. And then of those patients, of those 332 patients, they found that 80 of them, in other words, 24% of them, went on to develop a clinically significant lung injury. This means that these patients who had clinically insignificant lung injury are now developing some element of ventilator-induced lung injury. So there's an iatrogenic component to mechanical ventilation and the injury thereof. And so this suggests that perhaps the more acute, the more severe form of lung injury, in other words, acute respiratory distress syndrome, perhaps this too is an iatrogenic injury. And so this was another publication by Gajek, and this basically asked the question, is acute respiratory distress syndrome a hospital-acquired disease? Of course, mechanical ventilation is necessary to support the lungs of patients with injured and uninjured lungs, both, but at the same time, the way we're ventilating our patients, we could actually be providing a concomitant injury. And so what they did was they stratified patients according to the time at which they developed acute respiratory distress syndrome. So they found that a certain proportion of patients had ARDS on admission, a certain portion had ARDS on admission and had a recent hospitalization, certain ones were transferred from a nursing home, and some had a recent outpatient contact. The most important thing is that 67% of those patients developed acute respiratory distress syndrome after hospital admission. And if you look at the number of hours it took for them to develop acute respiratory distress syndrome, on average, the median of them developed ARDS at about 30 hours. Again, supporting the fact that what we're doing with our mechanical ventilator, if we're setting it injuriously, we could ultimately be harming our patients. So then this begs the question of, can we treat acute respiratory distress syndrome? And an even better question, can we prevent acute respiratory distress syndrome? This was a review by Mathé, and he looked at many of the major trials trying to find treatment strategies for ARDS. And unfortunately, we have really disappointing findings. We find that there's essentially no difference in mortality for the majority of our studies trying to treat ARDS, with one exception: lung protective ventilation. Lung protective ventilation to this day is the only thing that we've really been able to demonstrate consistently can reduce our mortality associated with ARDS. So what does it mean to have a protective mechanical ventilation lung strategy? I would argue that we can talk about lung protective strategies in one of three aspects, and every lung protective strategy does one of these two things, or one of these three things, excuse me, or a combination of these three things. One of them is, of course, low tidal volume. Now in this group, I don't think that I need to address the ARSNet trial. The ARSNet trial was such an exciting trial. This was the New England Journal of Medicine trial published in 2000. It was the first large randomized prospective controlled trial that demonstrated a decrease in mortality simply by adjusting the mechanical ventilation settings. This was so exciting. So if we look at the mortality rates, if we take the low tidal volume group and compare it with the traditional tidal volume group, we see that we drop down our mortality rate from 39.8% to 31%. And this is in a disease that has an incidence of about 170, 180,000 individuals in the US alone, which means that that 8.8% decrease in mortality could save up to 17,000 lives every year. So it's not surprising that this was not only an exciting trial, but it's launched multiple trials looking at low tidal volume ventilation, looking at ventilation in general and how we're setting our mechanical ventilation. And in fact, if we look back to the original graph that we showed, showing that the majority of our interest in VILI came after 2000, it very well could have been propagated by this study. Unfortunately, if we look at those low tidal volume trials, the ones that have been published after the ARDSNet trial, we see that the mortality rates have essentially remained unchanged. This was the LOVE trial performed in 2008, the EXPRESS trial 2008, the ALIEN trial 2011. Our mortality rates are still unacceptably high, despite the fact that we've found this fairly protective mechanical ventilation strategy, which means that although the idea of low tidal volume is a great one, perhaps we need to be thinking a little bit more about what it means to be a low tidal volume strategy. And then, of course, we could say, well, maybe the ARDS rates haven't changed because we're stratifying all of our severe and mild ARDS groups together. And so the LungSafe trial came out this year, and they stratified our patients according to mild, moderate, and severe acute respiratory distress syndrome based on the Berlin definition, and looked at the mortality rates therein. And we find that still, even mild ARDS, 35%, moderate, 40%, severe, 46%, we still have work to do. So when it comes to low tidal volume ventilation, ultimately the lungs that you're ventilating is very much going to depend how they're responding to the low tidal volumes. So if we, for instance, look at these nicely inflated, homogeneous, open, pink, healthy lungs, and if we were to zoom in and look at the alveoli, we would imagine that those alveoli are going to be nice and open, all have similar diameters, they're nice, they're not collapsed, there's nice homogeneity in them. And if we deliver a low tidal volume, a 60 cc per kilogram tidal volume on top of these nice healthy alveoli, we could imagine that they're all going to distend fairly symmetrically, fairly evenly, and they'll all be nice and open and persistently homogeneous. Now, if we compare it with this diseased lung here, now we have a difference in our alveoli. Now we have some nice open alveoli here, and we have adjacent collapsed alveoli, which means that when we deliver that low tidal volume, even with the idea that we're preventing over-distension, ultimately those low tidal volumes are going to preferentially distribute to those alveoli of larger compliance, while potentially leaving those remaining alveoli collapsed. And so this could actually propagate atelect trauma as well as barotrauma. So we were interested in really trying to establish the differences between lung tidal volume and alveolar tidal volume. Is there a difference? And so in this study, what we did is we took rat lungs. We used in vivo microscopy, where we place a camera directly on the surface of the lung and it established what the alveolar tidal volumes were. And if we start out with just a standard low tidal volume strategy, we're looking at the tracheal tidal volumes here, or the lung tidal volumes in black. And over here, we're looking at the alveolar tidal volumes. These are in blue. And all we did in this study is we changed the PEEP settings. We changed it from a PEEP of 10 to 10, excuse me, a PEEP of 5 to 10, all the way up to 24. And the tracheal, the lung tidal volume, we set consistently at 6 cc's per kilogram. And the only thing we wanted to see was how the alveoli responded to those 6 cc's per kilogram on top of different PEEP levels. So what we notice, and the values themselves are not really as important as the trend, what we notice at the low PEEPs, we have a large alveolar tidal volume, and once we start increasing those PEEP levels, that alveolar tidal volume slowly starts to descend, even though our lung tidal volume has remained the same. They're all being ventilated at 6 cc per kilogram tidal volumes. After a PEEP of 16, we find that there really is no change in the alveolar tidal volume, suggesting that maybe we've met our optimal PEEP in this particular rat population. So what this study taught us is that low lung tidal volume does not necessarily mean the same thing as low alveolar tidal volume. And moreover, to achieve low alveolar tidal volume, you need to be thinking about the lung upon which that tidal volume is being distributed. You also have to be thinking about the pressure within the system. And so this begs the next question. Does a large lung tidal volume necessarily mean that there's a large alveolar tidal volume? So to answer this question, we then brought in another group. We brought in an airway pressure release ventilation group. And in order to discuss the results of that study, the one thing that we have to talk about is the settings that we used for APRV. So this is the expiratory gas flow that we use to determine our T-low for setting our settings in APRV. So if we can imagine, we have our release time. We've just released our inspiratory phase, and this is our expiratory flow. This here is our peak expiratory flow. It's the maximum negative value that we achieve after our inspiratory release. And if we were to set our T-low optimally, we would try to set the termination of that peak expiratory flow at about 75%. If we allow that flow rate to decay to 0, we're essentially losing all of our lung volume. So we use our T-low to modify the end expiratory pressure. So if we set our termination of peak expiratory flow rate at 75%, we have a nice, appropriately short T-low. If we start extending out the T-low, then you slowly start to decrease that ratio. So then you get a ratio of 50%. And now you have a little bit less end expiratory lung volume. And further increases in your T-low or shortening up that ratio will slowly lead to less and less lung volume or a lower end expiratory pressure in our APRV settings. So back to the question, does large lung tidal volume necessarily mean that there's a large alveolar tidal volume? So we have a similar graph that we saw before, and again, we're looking at the tracheal, the whole lung tidal volume in black, and we're looking at the alveolar tidal volume in blue. And this time what we're doing is we're changing the T-low. Here we have a longer T-low or a lower end expiratory pressure. The termination of the peak expiratory flow rate is 10%, and we're shortening that T-low to get to what we would consider a slightly better, more optimal setting with a 75% ratio. And we see is that simply by modifying the T-low, first of all, our tracheal tidal volume slowly starts to go down. Over here, there's 17 cc's per kilogram. Down here with our 75% ratio, we're now down to 11 cc per kilogram tidal volume. And we see, similar to increasing PEEP in our traditional tidal volume strategies, we see that as we shorten the T-low, the alveolar tidal volumes slowly start to decrease until we get to 75%. But again, we still have fairly large tracheal tidal volumes at this point. So how does the APRV alveolar tidal volume compare to that of low tidal volume? If we look at the two settings that had the lowest alveolar tidal volume, that would be APRV set with 75% ratio and the PEEP of 16 group. And what we find is that in both scenarios, the alveolar tidal volume, the difference in the alveolar size between inspiration and expiration is just 0.025%, and that's true in both APRV as well as the PEEP of 16 low tidal volume group, despite the fact that in the APRV group, we have nearly double the tidal volume that we did in the low tidal volume group. And so this shows that really the whole lung tidal volume is not as important if we're not considering the alveoli upon which that tidal volume is being distributed. If you have a collapsed lung and you're distributing a low tidal volume, you won't necessarily have a low alveolar strain. And similarly, if you have a nice, open, recruited, homogeneous lung and you distribute a large tidal volume on top of it, you could still end up with a smaller alveolar tidal volume. So that covers tidal volume. Then the next question is, what about lung strain? This is a fairly new concept that's really come up over the last 10 years and has demonstrated decreases in morbidity associated with lungs by decreasing lung strain. So just to define stress and strain, stress is the pressure in the volume, the amount of pressure and volume that we're forcing into the lung. And the lung, of course, has to accommodate that stress. And the way that it accommodates it is with this strain. This was a publication that was published by Dr. Gattinoni's group, and they ventilated pigs for 72 hours, and they wanted to determine not only how much lung strain and how much the dynamic lung strain impacts mortality, they wanted to see if there was a difference between static strain and dynamic strain. And so what they did with these animals, they ventilated all of them to the same global lung strain, and the only thing they modified was the proportion of tidal volume and the proportion of PEEP, where the tidal volume is essentially the dynamic strain, and the PEEP is essentially the static strain. So starting out at the beginning, they started with entirely tidal volume and no PEEP, and so this is a component of all dynamic strain. By slowly increasing the PEEP, we're increasing the static strain, decreasing the dynamic strain, until we get to the end where we have just smaller tidal volumes and high PEEP. And what they found in this group is that there's a decrease in edema, improvement in oxygenation, improvement in histologic injury, as well as a decrease in inflammation. So this really started, again, getting us thinking a little bit more about strain, not only in the lung, but then in our group, also thinking about the alveoli. How much of what we're doing and setting on the ventilator, how much is that actually impacting the alveoli? And so just to look at some videos, we're going to look at the whole lung and determine how much strain there is in it. And then we're going to zoom in and look at the alveoli. So if we have, again, this nice, healthy, recruited lung, and we will see these nice, small tidal volumes across this whole lung, and we zoom in, we see that the alveoli are hardly moving. Again, this is with a microscope directly on the surface of the lung, and the alveoli are just very, very barely responding to the mechanical ventilation. So you can imagine that these alveoli probably have a fairly low alveolar strain. By comparison, if you take this quite injured lung, where we just have this baby lung that's inflating with every breath, you can see that in the alveoli, by comparison, are now bouncing open and closed. They're exercising with every single breath. You can imagine the alveolar strain that they're being exposed to. And so over time, that strain ultimately becomes injurious and can propagate further lung injury. Just to further establish what it means to have normal alveolar strain versus increased alveolar strain, we can again see in the image on the left, these alveoli are hardly moving. These alveoli are in fact being ventilated, but they're barely moving with response to mechanical ventilation. And what we're setting at the level of our ventilator, that's what we want to be seeing at the level of the alveolus. By comparison, this group, these alveoli are getting injured with every single breath, and this is what we want to try to minimize. So to further investigate the difference between lung strain and alveolar strain, really try to get a handle on alveolar strain, we designed a subsequent study, again using an airspace analysis where we quantify the degree of surface area within the alveolus, and then to thereafter calculate out the perimeters and the strain. So we did this using the same mechanical ventilation settings. We took low tidal volume ventilation, again 6 cc's per kilogram, and then we only modified the PEEP. And so if we look at our inspiration, PEEP of 5, PEEP of 10, PEEP of 16, PEEP of 24, we can see that as we slowly start to increase the PEEP, the number homogeneity of the alveoli and the overall surface area increases with our inspiratory breath. Similarly, if we look at expiration, going from a PEEP of 5, 10, 16, 24, we can again see that recruitment of alveoli are happening at the level of the alveolus. And even more specifically, if you look at the PEEP of 5 group, if you identify these two alveoli, you can see that they remain open at expiration. These are alveoli with nice compliance. The problem is that between expiration and inspiration, those two alveoli are going to see more strain than the remaining collapsed alveoli that never really have an opportunity to open up. And similarly, if you look at this cluster of alveoli here, we can see that these are fully collapsed at expiration, and then they open and over-distend at inspiration, potentially causing a great deal of alveolar strain. So if we could imagine that probably these settings over here, these higher settings, are going to have a lower alveolar microstrain. And of course, we looked at APRV as well, looking at the same settings. This is inspiration, and regardless of how we set our T low, our alveolar airspace occupancy at inspiration is really quite nice. There's a really lovely surface area in our APRV group, regardless of what our expiratory settings are. And this suggests that this is due to the time component of APRV. When we set our plateau pressure, we're spending a prolonged period of time at our plateau pressure, allowing for alveolar recruitment. The question is what happens when we do start lengthening, or rather in this case, shortening our T low. So now if we have a longer T low, we have a longer expiratory time, which means we are going to lower our end expiratory pressure. And we can see that only until we shorten up that T low do we start to see that those alveoli become homogeneous, occupying that similar surface area at expiration. And so only when setting that T low appropriately do we start seeing that there would probably be less alveolar strain between inspiration and expiration. So using our alveolar airspace analysis, we then were able to calculate the microstrain by looking at the perimeters of the alveoli and then calculating the strain based on the differences between the two of them. So if we start out by looking at the alveolar strain in low tidal volume ventilation, here we are alveolar strain. Again, we're going from PEEP of 5 up until a PEEP of 24. We see that the alveolar strain decreases as we start to increase our PEEP. And again, that alveolar strain seems to minimize at that PEEP of 16. By comparison, the alveolar strain in APRV, again, we see a similar type of curve as we move down, as we shorten up our T low and move to a termination of the peak expiratory flow rate more similar to 75%, we reduce our alveolar microstrain. And so the next question is, how does lung strain actually correlate with this alveolar microstrain? If we start out looking at the PEEP values, we see that the alveolar microstrain, which is represented in gray, is huge in the PEEP of 5 group, but the lung macrostrain is actually quite small. And so we see that the lung strain doesn't necessarily correlate with the degree of strain that the alveoli themselves are seeing. And by comparison, if we look at the PEEP of 16, we see that there's a low alveolar microstrain and there's a similarly low lung macrostrain. So in this case, the two happen to be similar. If we look at APRV set with a ratio of 10%, we see again that there's a large alveolar microstrain, just like what we saw in the low PEEP groups. And the lung macrostrain is also similarly elevated. So the two do happen to correlate in this scenario as well. But if we look at the APRV set at 75%, we see that the alveolar microstrain is actually lower than any of the others. But the lung macrostrain is actually similar, if not higher than that of the PEEP of 5. And so the two, again, are not necessarily similar. So this is just another example of how when we think about the lung itself, it doesn't necessarily correlate to the microenvironment, what the alveoli and also the alveolar ducts are seeing. So if we were to design a mechanical ventilation strategy that really thinks about the microenvironment and how the alveoli are responding to each of these individual breaths, we would ideally try to find some mechanical ventilation strategy down here in this right lower hand corner. And the reason for this is because this would represent a low alveolar strain strategy, but with high alveolar airspace occupancy. In other words, there's a large surface area and there's lots of alveoli that are being recruited and surface area upon which those tidal volumes are going to be distributed. So this is the aim that we have. And based on the study, this is what we actually found. APRV 75% fits right into this right lower hand corner. All of the APRV groups we saw had a really great surface area at inspiration because of that prolonged T high. But what we found is, again, we had to shorten that T low in order to really make sure that we weren't straining the alveoli injuriously. By comparison, the low PEEP groups have high alveolar strain, high airspace occupancy, and only once we start increasing our PEEP do we finally get to the point where we have more surface area and lower alveolar strain. So I've spoken quite a bit about the alveoli, but one of the things that we also tend to forget about are the alveolar ducts, which are of course going to be equally important in mechanical ventilation. If we can't get our pressures and tidal volumes down the conducting airways, down the trachea, down the bronchioles, then the alveoli never have an opportunity to see the pressures and flows. And of course, our conducting airway system is just as complex as our alveolar system. In this group, this was a mathematical group that looked at network analysis, trying to identify how conducting airways respond to mechanical ventilation. And what they did was they looked at, they color mapped it from green to purple, green being those areas that are poorly ventilated, and purple being those areas that are well ventilated. And we see is that there's heterogeneity even within the conducting airways going down to the alveoli themselves. And then the next question they wanted to ask is, can we recruit the conducting airways? Can we recruit them the way that we recruit alveoli? And so they established a recruitment maneuver, and the black lines are now representing where that pressure and volume is being distributed to. And so we can see at the beginning, we're going into the trachea and the main stem bronchi, and then we're slowly subdividing these into the bronchioles. But we can now start seeing that heterogeneity. We can see that this one cluster is just not seeing as much volume and pressure. And only until that sustained recruitment maneuver, this is a 30-second recruitment maneuver, do we have full homogeneity of the conducting airways. And just to remind ourselves, if we think about a typical airway pressure release ventilation waveform, we have a sustained time at our plateau pressure. In other words, APRV is essentially multiple sequential recruitment maneuvers. So we can imagine that we can probably recruit the conducting airways just as we could recruit the alveoli. And that was the question of our next study. Can we actually recruit the conducting airways? And can we do it not causing additional injurious strain to the conducting airways themselves? So we did another color mapping analysis, and we identified all of the conducting airways, specifically looking at the alveolar ducts, as well as the alveoli represented in blue, with everything else represented in red. If we look at the control histopathology, this is a rat lung, never before been mechanically ventilated, and has absolutely no element of injury, mechanical or otherwise. We see between inspiration and expiration, there's very little difference. These alveoli, are represented in blue. They're homogeneous, they're open, and they're similar between inspiration and expiration. If you look at the conducting airways represented in green, we see that they're present. They don't overwhelm the slide, but they're certainly available to deliver our pressures and tidal volumes to the alveoli. Now, if you look at the injured lung, this is APRV set with too long of a T-low, APRV 10%. We see that the conducting airways overwhelm the slide. The alveoli never really have an opportunity to recruit because of our prolonged T-lows, or rather they have too much of an opportunity to de-recruit. And so we see all of this conducting airway, and there's quite a bit of strain you can see between inspiration and expiration with less conducting airspace occupancy at expiration. APRV 75%, now by comparison, this looks much more like our control lung. We see those nice open alveoli, they're relatively stable even between inspiration and expiration. The conducting airways are certainly more prominent than they were in the control group, but they don't overwhelm the slide the way that the APRV 10% group does. By comparison, the PIPA 5, this looks very similar to the APRV 10%. We have all of these large conducting airways, and they're straining between inspiration and expiration, going large to small, and our alveoli are, again, very collapsed. And then again, PIPA 16, this looks much more similar to our APRV 75% group. Nice recruited alveoli and smaller conducting airways, but certainly more prominent than in the control group. Just looking at them side by side, not really looking at the details, but just looking at the overall patterns, we can see between inspiration and expiration, all of these injured lungs, none of them look similar to the uninjured lung, but APRV 75% and PIPA 16, they at least come darn close. Now, if we look at the actual conducting airway strain, we see that in the control group, we have minimal strain in the conducting airways, those alveolar ducts. But as we go to APRV 75% PIPA 16, we have slightly more conducting airway strain, but less so than PIPA 5 and APRV 10%. And just so we can remind ourselves, when it comes to the whole lung strain of PIPA 16 and PIPA 5, those were the two that had the lowest whole lung strain. And again, doesn't necessarily correlate with the lowest, in this case, alveolar duct strain. And finally, one of the other strategies that we can use to try to minimize ventilator-induced lung injury is minimizing lung heterogeneity. And this is the patient that we all have difficulties ventilating. This is a CT scan of a patient with acute respiratory distress syndrome. This is going from inspiration to expiration. And we can see that we have this nice non-dependent, relatively inflated lung, even at expiration. And then down here in the dependent region, we have all this consolidation and this atelectasis. And between inspiration and expiration, we can just imagine that all of our volumes and pressures, they're going to preferentially go to this already recruited, non-dependent area while potentially leaving this area collapsed. So we can essentially see a heterogeneous airspace gradient just in an anterior-posterior direction. You can even see it in a cranial-caudal direction if you were to look on CT scans. But I would argue that we can even see it at a microanatomical level. So if you look at alveolar heterogeneity, this is just looking at alveoli under the microscope, we can see that there's a great deal of heterogeneity just between individual alveoli that are adjacent to each other. And even more indicative here in this image, we see all of these lovely, beautifully open alveoli and this one area of just absolute consolidation just adjacent to it. Whereas here we have heterogeneous atelectasis, with atelectasis here just adjacent to open areas on either side. This isn't even really taking into consideration the fact that alveoli do not distend by themselves. They're all interdependent. They all have shared walls, which means that when we deliver a tidal volume, the alveolus is not going to respond by itself. It's going to also respond depending on how its neighbor is responding. So if we have a nice open set of homogeneous alveoli, and this is how hopefully our patients are being ventilated when they're first starting, this is how they look. But over time, we end up with one alveolus that becomes atelectatic. The remaining alveoli have to distend in order to accommodate it. Or by comparison, if you have one alveolus that's overdistended, the remaining have to somewhat collapse in order to accommodate that one. Not only that, we still do not have any idea how alveoli truly respond to the mechanical breath. We don't know whether the alveolus just recruits with every inspiration off of the alveolar duct. We don't know if there's isotropic insufflation where it's slightly smaller and then it gets slightly bigger. We don't know if they change shape or if the alveolar walls crumple and then they open up. We have a lot to learn at the level of the alveolus, but it's certainly an area that's worth investigating. This was a really great study. This was a study about a group by a group that radio-labeled edema and then instilled it into the alveolus. They wanted to see how the alveolus would respond to the edema and then respond to mechanical ventilation thereafter. So what they did was they took the control lung, this is at 5 centimeters of water for our alveolar pressure, and they went up to 15. And we see that the diameter of the alveolus slowly increases with that increase in pressure, as we would expect it to. Now, once you instill edema into this one alveolus, notice what happens to its diameter. The diameter goes down, and the neighboring alveolus, the diameter actually has to increase in order to accommodate for the diameter decrease in the adjacent alveolus. Moreover, once you add in additional pressure, now we see that the alveolus with all the additional edema, the diameter again hasn't changed, and the one next to it had to overdistend in order to accommodate for that increase in pressure. This again goes to show what we said on the mechanical ventilator doesn't necessarily correlate with the microenvironment, what exactly is happening at the level of the alveoli and the alveolar ducts. We do know, however, that lung heterogeneity is associated with increased morbidity and mortality in ARDS, and therefore trying to maintain open homogeneous lungs is a very valid, valiant effort. This was another study by Dr. Gattinoni's group. They looked at CT scans and they did inverted color mapping, trying to identify the regions of increased stress. This is a patient with normal, healthy lungs, and we can see that there's very little stress in this patient. All of the lung is mostly blue. By comparison, a patient with acute respiratory distress syndrome, we can see all these areas of increased stress, all this yellow and red. Not only do we have heterogeneity in the lung parenchyma itself, we have heterogeneity in the alveoli. And so we designed another study to try to identify how heterogeneous these alveoli are, and can we get them more homogeneous simply by using the mechanical ventilator. So again, we colored in these alveoli, and as we move from inspiration to expiration, we can see that these alveoli are hardly moving. These are nice, healthy, stable, homogeneous alveoli. But over time, certain of these alveoli are destined to collapse, and this could be due to prolonged mechanical ventilation, alveolar edema, surfactant deficiency. But as they collapse, this means that the neighboring alveoli need to distend in order to accommodate it. And if we look at the original alveolar sizes and shapes, we look at the new alveolar sizes and shapes, we can then see that the regions of increased stress as they're accommodating those collapsed alveoli. Moreover, we now recognize that we have this distinct population of very differently shaped alveoli as we had previously. Not only are they differently shaped, they're also differently sized. So if we again look at those same settings that we were looking at in the previous studies, this is a PEEP of 5 and a PEEP of 20, we can see that we lose all of these open alveoli at expiration. PEEP of 20, they look fairly similar, same with APRV 75% and APRV 10%. Again, we allow for all this extra alveolar derecruitment, so there's a really big difference in the heterogeneity of these alveoli. But if we were to design an optimal mechanical ventilation strategy, we could kind of plot out how we'd want our alveoli to look. So if we were to look at alveolar area here, the number of alveoli of that given area, if we were to set our ideal mechanical ventilation strategy, we would have minimal alveoli that are collapsed, very few alveoli that are overdistended, and a preponderance of alveoli that are normal sized. So we did this looking at those same ventilation strategy settings. And if you look in our control group, this is a set of rat lungs that have not had any injury, and we look at the heterogeneity of the alveoli. So we look at the alveolar area and then the number of those alveoli. We see that nice normal distribution. We see a majority of those nice normal-sized alveoli. Now, if you injure the lungs and now add on low tidal volume ventilation, this is at inspiration, moving up from a PEEP of 5 to a PEEP of 24. We see that in a PEEP of 5, we have this positive skew. We have this preponderance of smaller alveoli. And only once we start increasing our PEEP do we start to see this normal-sized population of alveoli manifest. And only until we get to PEEP of 24 do we have a slightly more normal distribution, although it still never quite achieves that of the control group. By comparison, if we look at expiration, again, this is the control group, and we see that nice normal distribution, just like what we would expect to see. Once we injure the lungs and we add on a PEEP of 5, we again see those collapsed atelectatic alveoli, just a couple of normal-sized alveoli, which slowly start to increase as we increase our PEEP values. But again, that curve never looks the same as our uninjured lungs. By comparison, in APRV, this is APRV at inspiration, so this is modifying again the T low so that we're terminating our peak expiratory flow rate between 10% and 75%, and we're going to compare it again with the control group. APRV 10%, 25%, 50%, 75%. At inspiration, we have a homogeneous population of alveoli that mimics that of the control group. In fact, these two are statistically similar. So at inspiration, with that prolonged T high, we're able to recruit out the alveoli. And the question is whether we can keep them recruited by shortening the T low. So now if we look at expiration, again, we're comparing it with the control group. We're going from APRV 10%, And this looks absolutely terrible. We have mostly collapsed alveoli, 25% starting to see those normal alveoli, 50%, 75%. More normal, but we're never able to get to the same expiratory, the same degree of homogeneity at expiration as we are in the control group. And this really tells us how important it is to protect the lung and prevent the lung injury from happening, because once the lung is already injured, it becomes progressively more difficult to recruit. So ventilator-induced lung injury is incredibly important. It impacts morbidity, it impacts mortality. But what I would argue is that we certainly need to be thinking about ventilator-induced lung injury, but more importantly, we need to be thinking about ventilator-induced alveolar lung injury. We need to be thinking about how what we set on the mechanical ventilator is really impacting the terminal airway, the alveoli and the alveolar ducts. Those are, after all, the working horse of the lung. That's where our oxygenation and carbon dioxide exchange is happening, and that's where injury occurs. So what I've hoped that I've done at the end of this is to review the impact of different mechanical ventilation strategies on the microenvironment, recognize that indeed there is a discrepancy between macroventilation and microventilation, and then reconsider what it means to be ventilator-induced lung injury. I'm going to digress just for a minute because I was asked to talk a little bit about chest wall mechanics as well. So I'm going to talk about one additional study, which is equally important when it comes to ventilator-induced lung injury, but has a little bit less to do with the micromechanics of the lung. So I'm going to talk about transpulmonary pressure and pleural pressure. And to really talk about transpulmonary pressure and pleural pressure, we need to be thinking about the different disease phenotypes of acute respiratory distress syndrome. And ARDS can be stratified into a number of ways, but it can really be largely substratified into either pulmonary ARDS and extrapulmonary ARDS. Pulmonary ARDS is anything that directly impacts the lung. This can be inhalation injury, aspiration, pneumonia. Extrapulmonary ARDS is anything that secondarily impacts the lung, and this is any combination of sepsis, trauma, hemorrhage, intra-abdominal hypertension, anything that's going to increase the intra-abdominal pressure and tense up the diaphragm, anything that increases chest wall edema can always be considered an extrapulmonary ARDS. The reason this is so important to distinguish the two is because the physiology of these two ARDS subtypes is really quite distinct. If we think about elastance, pulmonary and extrapulmonary ARDS both have an increase in respiratory system elastance. In other words, they have a reduction in respiratory system compliance. Pulmonary and extrapulmonary ARDS both have an increase in lung elastance, but the difference lies in the chest wall. In pulmonary ARDS, in general, we don't have an increase in our chest wall elastance, at least not initially. In extrapulmonary ARDS, we do. So if we think about, and this is going back to one of the original slides, looking at the mortality rates associated with ARDS in some of our studies. And if we look at some of our studies, these are again those mortality rates that we saw a little bit earlier. But the most important thing about these studies, one of the things I said is that we're not thinking about the microenvironment, and perhaps that might be related to the high mortality rates that we're still seeing. But the other argument that I would make is that we're not really stratifying the patients that we're ventilating. So if we look at those patients who have pulmonary ARDS and those that have extrapulmonary ARDS, we notice that all of the trials evaluate all of them as though they have the same disease phenotype. And the truth is that these two disease phenotypes, they both respond to mechanical ventilation slightly differently. So if we take a nice healthy set of lungs in a nice thin individual and we deliver an airway pressure, a certain proportion of it is going to be distributed to the lung as transpulmonary pressure, in other words, lung stress. Another proportion of it is going to be distributed to the chest wall as pleural pressure, and that's going to work to combat any chest wall edema, obesity. If there's any element of intra-abdominal hypertension, then that pleural pressure is also going to work to combat that additional pressure. So you can imagine ventilating a patient like this is quite different from ventilating a patient like this. If you have a patient like this, we really need to be thinking about how much of our pressures are going towards descending the chest wall, because we need to recruit the chest wall if we're able to also recruit out the lung. So how do we partition the respiratory system? This was another study by Dr. Gattinoni's group. He looked at pulmonary acute respiratory distress syndrome, and he looked at how the elastance was partitioned. And in patients with primary pulmonary ARDS, the respiratory system elastance was high, the lung elastance was high, the chest wall elastance was relatively low. In extrapulmonary ARDS, we see that the respiratory system elastance is similarly high. The lung elastance is also high, but in this case, we also have an increase in our chest wall elastance. So part of the injury in extrapulmonary ARDS really is this chest wall elastance. And what they wanted to do was really try to figure out how these two groups of individuals responded differently to PEEP recruitment maneuvers. So if you increase the PEEP in the patients with in pulmonary ARDS, we see that there isn't really much of a concomitant change in volume. These patients have very non-compliant or high elastance lungs, and increasing the PEEP didn't seem to make a difference. In extrapulmonary ARDS, these patients also tend to have high lung elastins, but they also have high chest wall elastins and an opportunity to recruit the chest wall, which means that when we increase the PEEP in these patients, we ended up with a large concomitant change in tidal volume, suggesting that these patients are PEEP responsive. So this then begged the next question: can we ourselves try to recruit the chest wall simply by modifying the pressure? And so this goes back to one of our earlier studies in 2013 published by Shreyas Roy. He looked at the pressure time integral. He looked at the waveforms between low tidal volume ventilation and airway pressure release ventilation to try to determine how much pressure is being just delivered to the lung, as well as, in this case now, to the chest wall over a given respiratory cycle. And so if we look at the area under the curve, we can see in low tidal volume, because we have a brief inspiratory phase and a prolonged expiratory phase, we have a lower pressure time integral as compared with APRV with that long plateau pressure, long P high. So we know that APRV has a higher pressure time integral. The question is, can we also recruit out the chest wall in addition to recruiting the lung? So we designed a study. This was a 48-hour porcine model, and Gary's going to be talking quite a bit about some of our models later. This is a high-fidelity, robust model that mimics extrapulmonary ARDS very well. There's chest wall edema, there's high-volume resuscitation, there's sepsis, there's intra-abdominal hypertension. And what we see in the APRV group, we're looking at the plateau pressure. APRV is represented in blue. Low tidal volume is represented in this turquoise. We're going from baseline up until 48 hours, which is our study endpoint. We see that the plateau pressure slowly starts to increase over the duration of the study in APRV, such that the plateau pressure is significantly higher in the APRV group as compared with low tidal volume ventilation. Moreover, we're actually ventilating these patients at plateau pressures above 30 centimeters of water, which is standardly considered to be injurious. More important than the plateau pressure is how this plateau pressure is being partitioned to the lungs and to the chest wall. And we notice, again, APRV is represented in blue, low tidal volume is represented in turquoise. The transpulmonary pressure between these two groups was statistically similar, despite the fact that the plateau pressure was significantly higher in the APRV group. By definition, that means that the pleural pressure must be higher in the APRV group. In other words, more of that pressure is actually going out towards distending the diaphragm and towards recruiting the chest wall. And so that's exactly what we found. The pleural pressure was significantly higher in the APRV group as compared to the low tidal volume group. And by the end of the study, the lung elastins actually was reduced as compared with pre-injury, and the low tidal volume group lung elastins continued to increase. Similarly, the chest wall elastins in the low tidal volume group, without that additional pleural pressure, was also significantly higher as compared with the APRV group. So when we partition the airway pressure, if we look at the plateau pressure, and again, this is looking at the APRV group, the plateau pressure is slowly starting to increase. The transpulmonary pressure is staying relatively similar over these 48 hours, maybe a little bit of an increase here towards the end. And it's the pleural pressure that's increasing, again, to try to recruit the chest wall. So if we compare APRV, this is the same figure that we saw before. The plateau pressure is represented by the dark black line. The transpulmonary pressure between these two groups is similar, and it's the pleural pressure that's increasing in the APRV group. And we found at the end of the study is that there was decreased histologic injury, improved oxygenation, decreased oxygen requirements in the APRV group. If we think pictorially about exactly what's happening, and this is looking at the lungs and the chest wall in cross-section, we're looking at the low tidal volume group. This is just the pressure waveform. We're starting at expiration. As we move into inspiration, our lungs have the time to recruit during that tidal volume. But then with a prolonged expiratory phase, we could potentially not only allow for lung derecruitment, but maybe even chest wall derecruitment, such that by the time we move into our next inspiratory phase, we don't have that time necessary to re-recruit the chest wall. By comparison, if we start with APRV, again looking and starting at the expiratory phase, as we move into inspiration, we have that time necessary to not only open up and recruit the lung, we could potentially also be recruiting the chest wall. And with a brief expiratory phase, ideally we're not allowing for lung derecruitment, and we're also trying to avoid chest wall derecruitment. And so to conclude, macroventilation parameters, the PEEPs, the tidal volumes, the plateau pressures that we set on the ventilator, they don't necessarily tell us how the alveoli and the alveolar ducts are seeing those pressures. Moreover, it also doesn't take into consideration the chest wall. So rather than considering the impact the ventilator has on the lung, we really need to be considering the impact the ventilator has on the microenvironment. I'd like to thank everyone in our lab. We have an incredible group of individuals. And I think that we're going to be taking questions at the very end after all of the talks. Thank you so much.